Good evening, everyone. On behalf of the Voice Clinic Dinanath Mangeshkar Hospital, we welcome you all back to yet another session of Laryngology Back to the Basics. Before we proceed forward, I would like to inform that this lecture shall be the last lecture of our first module, which is voice. From next month onwards, we'll begin our next module, which is airway. Like all the previous sessions, today we have four eminent personalities who have expertise in the field of laryngology. Dr. Gandhi sir will introduce our speakers. Over to you, Gandhi sir.
Thank you, Darshil. Good afternoon, everybody, and welcome to another academic session in laryngology. Now, we'll concentrate today on management of early glottic malignancies, from diagnosis, investigations, management, and how we learn through. I'm very happy to introduce Dr. Firial from Oman. She is working as a laryngologist at Sohar Regional Hospital, Ministry of Health in Oman. She has done her post-graduation in Oman and head and neck surgery fellowship also in Armed Forces Medical College in Oman. I'm very happy to see our student of this institute. She has been fellow of Royal College of Surgeons, which we conduct a one-year fellowship at Dinanath Mangeshkar Hospital, and she has completed the fellowship and now working as a laryngologist in Ministry of Health, Oman. I will request Dr. Firial to start her presentation on premalignant lesions of the larynx. Over to you, Firial.
Hello everyone. I'll be speaking today on a brief about laryngeal dysplasia, premalignant lesions of the larynx. Laryngeal cancer presents 2.4% of all cancers globally, with the glottis being the most commonly affected subsite, and squamous cell carcinoma is the most commonly encountered histopathological type. Like any other cancer in the head and neck region, early diagnosis results in early management and gives better oncological outcome. Now, premalignant lesions of the larynx are lesions that might have a morphology of a benign pathology, but in histological examination, it can harbor cellular dysplasia or a tibia, which means they can progress on the long term to establish laryngeal carcinoma. So these lesions are not yet malignant, and this creates a dilemma, whether to treat or not to treat. If you treat, you might end up with over-treatment, and if you don't treat it, you might end up with under-treatment, as the progression to carcinoma will result in more morbidity. That's why it's very important to recognize premalignant lesions of the larynx and identify the risk factor for the malignancy transformation. So these premalignant lesions of the larynx, based on the morphology, is leukoplakia, erythroplakia, and erythroleukoplakia. And when we say laryngeal dysplasia, dysplasia is used to describe the macroscopic cellular atypia that's seen on histological examination of these lesions. So out of these three lesions, leukoplakia is the most commonly encountered premalignant lesion of the larynx. So leukoplakia means any white lesion of a mucosal membrane. In 1978, WHO defined leukoplakia as a white patch or plaque that cannot be characterized clinically or pathologically as any other disease. Since then, the definition underwent multiple changes and modification. It was not until 2007 when the WHO redefined it as a white plaque of a questionable risk, having excluded other known diseases or disorders that carry no increased risk of cancer. And this is considered to be the most accurate definition to define leukoplakia and its risk of malignancy transformation. The presence of leukoplakia indicates the presence of keratin on the surface of normally non-keratinizing mucosa, which indicates loss of a normal physiological function of that surface. As you can see in this picture, there is keratin deposits on the anterior two-thirds of the right vocal cords, which is normally non-keratinized surface. Now, this mucosal alteration of leukoplakia can be seen in 4.2 per 100,000 people in the United States, and it's more common in males than females, with the male gender being an independent risk factor. The median age of leukoplakia incidence from 61.7 to 63 years. And usually these lesions happen in the medial and superior edges of the middle one-third of the vocal cord and anterior commissure. These mucosal alterations can happen secondary to chronic laryngeal irritation that can be caused by tobacco and alcohol consumption, chronic exposure to laryngopharyngeal reflex, chronic exposure to chemicals and vitamin A deficiency, and human papillomavirus. Now, tobacco and ethanol consumption is thought to have a synergistic effect that increases the likelihood of malignancy transformation, and if laryngeal cancer develops, it results in an invasive type of squamous cell carcinoma. In the case of tobacco, the risk can decline 14 years after smoking cessation but persist up to 40 to 45 years post-cessation. Now, there is no specific presentation for leukoplakia. The patient can come to the ENT clinic with an incidental finding while the larynx being inspected for another purpose, like in the case of intubation or OGD, or while being evaluated for dysphonia or irritative symptoms like cough, throat irritation, and foreign body sensation. However, these symptoms, if present, it may not be due to the leukoplakia itself, rather secondary to the cause of the chronic laryngeal irritation, like tobacco inhalation or reflux. When the larynx is inspected by videolaryngoscopy, leukoplakia can be classified based on its morphology to homogeneous leukoplakia and non-homogeneous leukoplakia. Homogeneous leukoplakia is further divided to smooth leukoplakia and non-smooth thick leukoplakia. And in compared to the non-homogeneous type, homogeneous leukoplakia is thought to have less likelihood of harboring dysplasia in compared to the non-homogeneous type. The non-homogeneous leukoplakia itself also divided to speckled, nodular, and varicose leukoplakia. And speckled leukoplakia that represent erythroleukoplakia is considered to be the most commonly encountered type of the three. On stroboscopic evaluation, leukoplakia can have different status of the mucosal wave. The mucosal wave can present and be completely normal. The mucosal wave can be present but reduced, or it can be completely absent. Whether present or not, it may not be specific to the presence of dysplasia and malignancy transformation, as the mucosal wave can be affected if the lesion mass effect present on the vocal ligament and muscle, or if there is infiltration of the lesion itself into the ligament and the muscle. So it's not sensitive to the presence of dysplasia nor specific for malignancy transformation. However, stroboscopy can be a very useful tool on the follow-up process to determine the increase in thickness and depth in leukoplakic lesions. Narrowband imaging with or without stroboscopy can also be used to evaluate leukoplakia. Narrowband imaging will highlight the presence of angiogenesis around the lesions or through the lesions, which indicate high metabolic activity of that tissue. The European Laryngeal Society classification for narrowband vascular changes of the glottic lesions is the most widely used classification. So in the ELS classification, if the lesion is premalignant, it is thought that the vessels will be coming from the deeper tissue or the deeper layer toward the surface. So they will appear as dots within the lesion or near the lesion. However, if the leukoplakia is thick or if it's cover more length of the surface, then the narrowband imaging may not be useful as it will not show the superficial vessels, like in this video. Now, all the previous modalities of inspection of the larynx, the videolaryngoscopy, the stroboscopy, and the narrowband imaging lacks the sensitivity and the specificity to identify the leukoplakia that can harbor dysplasia or the leukoplakia that has the potential of malignancy transformation. And so, a white patch on the mucosal membrane of the vocal cord still will include a benign pathology, including the laryngopharyngeal reflux, laryngeal infections like TB, and fungal infections, and mucus aggregation. Now, this dilemma will take us back to the point of argument, how to decide on what to do further for this leukoplakia. Will you overtreat or will you undertreat? Now, if present, we need to focus on the following. So the mainstay treatment of leukoplakia consists of determining the severity of pathology and the risk of progression to malignancy, eradicating the disease, demonstrate at least severe dysplasia in oncological procedure, and respect or improve the quality of voice. A thorough history and clinical examination are essential to decide on which leukoplakia can go for trial of medical therapy, and which leukoplakia can go for biopsy, or which leukoplakia can go for endoscopic surveillance without medical or surgical intervention. Age and gender, identifiable risk factors, and the associated history of the differential diagnosis like cough, fever, travel, asthma, DM, steroids, obesity, and poor voice hygiene with the stroke findings. For example, if we have a male patient who is more than 60 years of age, tobacco user, alcohol consumer, and in his video laryngoscopy, there is an unhomogeneous leukoplakia and in stroke has a reduced or absent mucosal wave, then the likelihood of this leukoplakia harboring dysplasia is high, and so the patient can proceed with biopsy. On the other hand, if a male patient, non-smoker or a smoker, and have history of dry cough, fever, or trouble, then infective laryngitis can be considered, and so forth. This is one of the cases we've seen in DMH in the last few months. This was a 60-year-old male patient who presented with dysphonia and a dry cough for 3 months. He was a tobacco user, chewable form, and smoked for more than 30 years, an occasional alcohol consumer, and works as a farmer. His video laryngoscopy showed a white patch on the membranous vocal cord, ventricle, and the ventricular band. And his video stroposcopy showed a present mucosal wave and a normal in appearance. The patient had trial of PPIs with no improvement, and so biopsy was proceeded because of the appearance of the subglottis. There is also like leukoplakia in the subglottis. And the final histopathology came as mycobacterium. And so this patient was managed with anti-TB medications. So it's very important to take a thorough history and modify the treatment plan according to the findings. So we need to remove the risk factor like stop smoking, stop alcohol, trial of medical therapy as I mentioned in terms of antifungal, anti-TB when appropriate, aggressive anti-reflux therapy, whether the patient have features of laryngopharyngeal reflux or not, because eventually it will affect your surgical outcome, and biopsy. Now biopsy can be indicated or can be preceded if there is high clinical suspicion based on the history and the VLS, stroposcopy, and NBI findings, or if there is no improvement after anti-reflux therapy or medication, or there is a progression in the appearance and the location of the leukoplakia on serial endoscopic surveillance. Once indicated, one will have to answer 2 questions regarding the biopsy. Are we going for office-based biopsy, or are we going for examination under general anesthesia and then biopsy? And for the biopsy itself, are we going for a diagnostic biopsy or diagnostic and therapeutic procedure in a single setup? It's preferred that for the first time or first biopsy, examination under anesthesia is done for mapping of the lesion, palpation to know the depth, and also that the excision can be done at that time with phonosurgical technique like a microflap technique to preserve the vibratory function of the vocal cord. And if indicated afterwards, office-based procedure can be done. Now there are 2 thoughts of school regarding the type of biopsy. We can go for a biopsy setup only, and then after that follow with the in the OPD setup. If severe dysplasia is present or carcinoma in situ, then the patient can be taken in another setup for a second surgery. Or we do diagnostic and therapeutic procedure in which excisional biopsy is done, frozen stent, and if severe dysplasia or carcinoma in situ present, then chordectomy can be planned accordingly in the same setup. Narrowband imaging can be used in this option to map the lesion. Once the biopsy is sent and the histopathology come, the degree of the dysplasia in the biopsy will define the risk of malignancy transformation. It will determine the surveillance plan, the frequency and the interval in the visit, the interval of the visits, the need for further biopsies, and the extent of revision excision if required. At the moment, there are no guidelines or recommendation on the surveillance plan for leukoplakia. So the degree of dysplasia will determine that. And so the degree of dysplasia or the histological grade is considered to be the only marker to assess the risk of malignant transformation. There are multiple grading systems that aim to give a prognostic value to the degree of dysplasia, and commonly WHO classification of histological grade of leukoplakia is used. The mean time of malignant transformation if the initial biopsy showed a benign at diagnosis range from 5 to 10 years. The WHO classification of leukoplakia histological grades the leukoplakia on 4 grades. So it can be either hyperplasia, keratosis or parakeratosis, mild dysplasia, moderate dysplasia, severe dysplasia, or carcinoma in situ. A pooled meta-analysis showed that the overall risk of progression to malignancy among patients with vocal cord dysplasia is 14.1 within 5 years of the diagnosis, and the risk of invasive cancer requiring radiation therapy and/or total laryngectomy is between 1% to 9%. So based on that meta-analysis, if the patient have hyperplasia, then the risk of malignant transformation within 5 years is 0. If the patient have mild dysplasia, then the risk of malignant transformation is 5% within 5 years of the diagnosis. And if the patient have moderate dysplasia, it's 15%, and if severe dysplasia or carcinoma in situ, the likelihood or the risk of malignant transformation is 40%. Aside from the histologically grade and the WHO classification as a predictor for the malignancy transformation, biomarkers are currently under research or under study as future prognostic indicators. The genetic alterations of the following gene, like cyclin D1, P53, and P60, can have a role in predict which tissue can have malignant transformation in the head and neck area, including the larynx. So in conclusion, pre-malignant lesions of the larynx, any degree of dysplasia has the risk of malignant transformation within 5 years of the diagnosis. As the severity increases, the likelihood is increased, and so long-term surveillance and early intervention is required. Prognostic markers is only histologically grade and maybe in the future the biomarkers. That's all from my side. Thank you very much.
Thank you, Firial. It was a nice, wonderful presentation. As she has already narrated in her last few slides, there are markers available which can tell us the chances of pre-malignant lesion on biopsy, the chances of going into malignancies in a later stage. These are P53 and other markers. Most of the institutes do have this facility. Like in Dinanath Mangeshkar Hospital, this is available, and we are doing it for all our patients who we operate for early laryngeal cancer lesions like leukoplakia and erythroplakia, hyperplasia. And they do tell us about the progression of the disease, likely progression of the disease, and maybe following these patients would have another database with us, which we will do. Thank you, Firial. We will move on to our another presentation by Dr. Rakesh Srivastav. He is consultant laryngologist at Sushrut Institute of Plastic Surgery in Lucknow. Again, very happy and proud to say he is also a product of Dinanath Mangeshkar Hospital Fellowship Program and doing a marvelous job, especially in pediatric airways and laryngeal malignancies in northern part of India in Lucknow. He has moved on in last few years to newer imaging systems in diagnosis as well as surgical application of lasers in laryngology. I would like to hear from Dr. Rakesh Srivastav mainly the importance, the clinical applications and significance of having the newer photodiagnostic tools like narrowband imaging, eye scan, that is intelligence scan, and the newer technology which is coming in various endoscopic systems. Dr. Rakesh Srivastav.
Carcinoma, diagnosis and principles of management. WHO has classified early glottic cancers on the basis of histopathology into various categories like hyperplasia, keratosis, mild, moderate, severe dysplasia, and carcinoma in situ. As the degree of dysplasia increases, the chances of malignancy is higher. There are two other variants which have been added, like on the basis of histopathology. What is microinvasive carcinoma, other is microcarcinoma. So microinvasive carcinoma is a carcinoma which is a superficial spreading with a maximum size of 10 by 10 by 3 mm in size, while microinvasive carcinoma that has not yet infiltrated the muscle or vocal fold, that are microinvasive type. These are the various categories which has been classified on the basis of histopathology, but on a endoscopic picture, these are the different look which you can suspect in a high definition laryngoscopic pictures. So this is squamous cell hyperplasia with mild dysplasia. So it looks like a white flat lesion on the vocal folds, which is indicative of mild dysplasia. So lesion with the exhibit keratosis and squamous cell hyperplasia with occasional nuclear atypia on histopathology. These looks like a white raised lesions with a breakage of capillaries at the periphery of the lesion, like this one here. There is a white raised lesion there, and this is indicative of moderate dysplasia. And there is a grade 3 or the carcinoma in situ, where there is a squamous cell hyperplasia and nuclear atypia in all areas of epithelium with basal cell proliferation and mitosis without going deep into the basement membrane. So workup of early laryngeal cancer is, first is video stroboscopy and voice analysis. Video stroboscopy and voice analysis. So video stroboscopy, after that there is a high definition laryngoscopy, then optical image enhancement technology like narrowband imaging, then imaging by HRCT or MRI, and peroperative assessment using high definition of 4K imaging. So voice related quality of life assessment is very important. One has to know about the Grebas score and acoustic analysis using various types of software like Pratt, or one can use is by Pentex, K-Pentex software, in which you can analyze the quality of voice and acoustic analysis can be done. So image enhancement technology like narrowband imaging, it has recently been picked up in last 10 years, and it has definitely made the laryngoscopy, the quality of the high definition laryngoscopy is far more better. Normally we all know that white light endoscopy comprises of 3 lights, but in NBI we use only the blue and the green light, which has got a different wavelength and which gives a different picture on using the tool with a greater precision. So this is the first classification which has come up for the early laryngeal cancers using a narrowband imaging. It clearly shows the depiction of various stages, how the cancer develops once the airway is exposed to the pollution and the changes which happens with the stage. So type 1 and the type 5 is indicated of cancer, while early lesions which are type 3 and type 4 are dysplastic lesions, and this is indicative of chronic laryngitis where there is a dilatation of the capillaries is there, and then there is a breakage of capillaries. This is like a white lesion with the underlying capillaries there. Mild dysplasia, this is moderate dysplasia, that is type 4, and now then there will be a slightly more dots are there, brownish dots, and this is like a capillary or earthworm type of feature which is clearly seen in squamous cell carcinoma. And if it is get very advanced and there is a lot of slough is there, so capillary structure it get destroyed, and very few capillary network you can see it, but more of the slough is there, and both these last two categories are squamous cell carcinoma. So the tricks of NBI is one has to use the scope more wisely, and one has to do the assessment at a very close range. So this is a trick which one has to learn using a flexible bronchoscope and examine the larynx at a very close range so that you can see the finer details. The nearer the lesion and better it will be for the assessment because it improves the pixel power of the scope. So here you can see in the periphery of the lesion there are brown dots and there are worm-like structure like this one, which is indicative of carcinoma. Type 2 pattern indicates of oblique capillaries which is coming from the ventricular side, and these are indicative of chronic laryngitis. Type 3 pattern is umbrella-like lesions, squamous hyperplasia and mild dysplasia, in which you can see the capillary which is coming from the ventricular side, and under the white flat lesion you can see the distribution of the capillaries there. So this is indicative of mild dysplasia. This is type 4 pattern, is small dark brown dots. You can see in between there is a white lesion there on NBI, and these are mild to moderate dysplasias. Like this on the periphery of the lesion, which is indicative of small brown dots. The capillaries look like here the arborescent capillaries are there, multiple branching is there, and these capillaries they break into small dots, which is indicative of moderate dysplasia. These are the very confusing lesions like umbrella lesions, submucosal vascular pattern hidden under the hyperkeratotic surface, and in these cases one has to go with the assessment of the periphery. This lesion doesn't show any of these features, so this the histopathology this matches with the moderate dysplasia or hyperkeratotic lesion. Type 4 pattern is again the same type, interpapillary capillary roots showing a high density with a speckled leg. So if you see this lesion on white light endoscopy, it doesn't show any of the characteristic, but here you can see these are the small brown dots are there, which are indicative of severe dysplasia. Type 4 pattern again, these are the earthworm type of capillary structure is there. This is indicative of squamous cell. Type 5B with inflammatory changes. Again inflammatory changes, we have to look at the periphery. Again we can see there are changes which is indicative of this thing. Now coming to another component of it, that is tumor segmentation in mixed lesion which has got one lesion might have a 2 or 3 pattern with it, but once we are reporting that lesion we have to report it with the highest features which fit into the knee classification. If one side shows a mild dysplasia, other side shows moderate dysplasia, the third side shows typical of type 5B pattern, then we have to report it as type 5B pattern. And separately we have to report it right or left chord separately, not like in a single go. Or site specific also we have to mention it like that. So NBI has really made the change in pre-operative assessment and per-operative also, and it has shown that it's great this thing, and it has been shown in early glottic cancer the impact of close and positive margin. The use of NBI has greatly affected the result. Coming to the image part of it, again if we see it here, this was a lesion which was there in the anterior commissure. If we see it here in this part of it, you can see there is a little bit indentation is there, which is again high resolution laryngeal MRI. Disadvantage of routine MRI is because of the motion artifacts are there, but with the introduction of dedicated radio frequency coil, the resolution is up to 1 mm, and MRI can easily differentiate between a tumor, edema and fibrosis. It detects early mucosal, submucosal regress, and especially helpful in cases in patient who has undergone radiotherapy. So diffusion weighted MRI, where the diffusion motion of water in tissue has to be detected, and ADC values is easily differentiate between a benign and malignant tumor, characterized by and its the water content into it, and the primary tumor, secondaries and metastasis can be easily seen with diffusion weighted MRI. So image is must in cases of deep infiltration of vocal cords, involvement of anterior commissure body of arytenoid, lesion extending to superior arcuate line into the ventricle or subglottic or supraglottic extension. Not in all cases, or in cases where the mid-cord lesion is there, the imaging has got its is no role in mid-cord lesions. So MRI shows a sensitivity of 100%, specificity of 97% in assessing areas like paraglottic, anterior commissure, thyroid and arytenoid cartilage. Kuno et al. In 2013, accuracy of CT scan in image staging is 80%, and well, as compared to it, 87.5% for MRI. And integration of newer techniques like radiofrequency coil and diffusion weighted MRIs increases the specificity of MRI in such cases. CT scan has got a sensitivity of 46 to 74% with a specificity of 87 and 94%. Baker claimed higher sensitivity of MRI than CT scan, but specificity is different, 84% versus 94% with CT scan. So early stage anterior commissure carcinoma cartilage invasion rate is 8.5%, but as soon as the stage goes up to T2 stage, the anterior commissure invasion chances as 20%. Whether to do biopsy or not to do biopsy is also controversial, especially early glottic cancer. Performing biopsy to classify grade of dysplasia is limited because of risk of misclassification. So many pathologists have got a different say on a same specimen. So official random biopsies may be insufficient because the biopsy is not taken up from a right place and underdiagnosis is there. Sometimes you have removed the whole of the tumor and it creates a confusion whether one should take up patient again for the second surgery. Following biopsy, the healing process causes inflammation, fibrosis. So this fibrosis sometimes in deeper plane, and it creates a confusion, especially if once we are doing a hydrodissection technique for early glottic cancer. Perioperative clinical examination, I have already pointed out, it's got a immense help, especially like this case with the supracommissural growth, and this is on the right side of the screen. This is on a white light endoscopy. It shows irregularity, but once we move it from white light to NBI, image enhancement technology, so you can see the small brown dots are there in the right side anterior vocal fold. Using a different angle telescope, so now you can see this thing. This is indicative of moderate to severe dysplasia. Finally, the histopathology came is moderate dysplasia. So very early mucosal subtle changes can be detected with NBI. CT scan looks normal. So performing a narrow margin correctomy for T1 glottic carcinoma is oncologically safe, and it has got a good voice outcome, especially in type 1, type 2 and type 3 correctomy. So single stage transoral laser surgery spared the time and burden of second operation, and physician consultation, operating room and hospitalization cost is very less if the patient is taken up for a single stage transoral laser surgery. The result of transoral laser surgery depends on multiple factors like intraoperative diagnostic workup, experience of surgeon and team, post-operative follow-up, pre-operative diagnostic workup, imaging already discussed. Patient selection is very important, especially the laryngoscope, and adequate laryngeal exposure is very important. One surgeon should have a good various types of laryngoscopes to visualize difficult areas like anterior commissure. So we are focusing mostly on the early glottic cancers like dysplasias and T1, T1B and T2A. These are the early glottic cancers. So ideal goal of a transoral laser surgery is most adequate therapeutic approach, ensure highest oncological success in the range of more than 90%, and lowest impact in terms of morbidity and the cost. So criteria for laser resection is mid-chord lesions, easily exposed larynx, good risk for general anesthesia, no involvement of anterior commissure, subglottic or ventricle or vocal process. Multicentricity is common with carcinoma in situ. Excision of dysplasia is advised rather than radiotherapy. So superficial spreading tumor at multiple sites, TLM, transmural surgery is better than radiotherapy. The technique that is known as hydrodissection technique using a saline epinephrine infusion, and it helps in delineating the tumor very well. It helps at the heat sink, and it prevents bleeding there. And tangential dissection is easier if you use a saline epinephrine infusion there. The European Laryngology Society has classified chordectomy into various types, and the type 1 to type 5 is first classification in 2001, and later on the type 6 has also been added into it, knowing the extent of disease. So extended chordectomy type 5 again been divided into A, B, C, D, and anterior commissure and contralateral chord. Arachnoidectomy C, type 5C is ventricular fold excision, and type D is subglottic, that is 1 centimeter below the chords. Type 6 chordectomy, when there is a supracommissural growth and something like a transglottic growth, anterior commissure extension or anterior commissure without cartilage invasion, that is the indication for type 6. Bilateral anterior chordectomy with commissurectomy is done. Resection of Broyles ligament and subglottic mucosa and with cricothyroid membrane. If tumor is in contact with cartilage, resection may include anterior thyroid triangle, so that can also be included into type 6 chordectomy. So if exposure of anterior commissure is good, the local recurrence rate of T1, T2 can be 17% regardless of anterior commissure involvement. That is by the largest series with Steiner in 2009. So this is a diagrammatic representation of type 6 chordectomy, that is supracommissurectomy. Subepithelial chordectomy, again like this. It is used for both for diagnostic, as I told you about, single stage, and indicated for hyperplasia, dysplasia, and carcinoma in situ without microinvasion. Transmuscular chordectomy or type 3 chordectomy is indicated for small superficial cancer extending up to the muscle. Infiltration is not deep and the mobility of the cord is good. So the section of epithelium, superficial lamina propria, and vocalis muscle is done. So you can see in the diagram there is a, up to that, it is not through whole of the muscle mass, but the vocalis part of the vocalis is excised with the tumor itself and the ligament and the superficial lamina propria with it. So after exposing, doing the ventriculectomy, removing the false cord, we can know literally the lateral extent of the tumor and do the type 3 chordectomy like in this case. Total or complete chordectomy, that is type 4 chordectomy, is done for T1A glottic cancer. Excision from vocal process of arachnoid to the anterior commissure laterally to include the inner perichondrium of thyroid cartilage. Ventriculectomy in such cases helps in greater exposure and to have a complete chordectomy, that is type 5, without ventriculectomy is not possible. Type 5A extended chordectomy involves the anterior commissure with contralateral vocal cord is excised. So dissection begins above the insertion of vocal ligament at the base of the epiglottis near the petiole and passes through the Broyles ligament. So this video and this diagrammatic representation indicates, so it's indicated for omega shaped, partially omega shaped growth, which is almost reaching up to the anterior commissure, and separation is started using a the black section, the laser section tube to separate the tumor from the inner pericardium near the anterior commissure. Extended correctomy type 5B includes the part of the arachnoid like this in this. Extended correctomy type 5C includes the part of the false cord where the ventricular fold growth excision is done up to that part. And removal of whole of ventricular fold together done with part of the vocal folds. These are all cordectomies. They have a link there, and even in my YouTube channel one can see all these various types of cordectomy on my YouTube channel. So type 5D extended cordectomy, which has included the subglottic mucosa. Then type 5-6 is tumor originating from the anterior commissure. Supracommissural growth is there, and this patient has undergone type 5-6 cordectomy. Surgical specimen were pinned on the cork or a board, and normally what I usually does is if I have suspicion of any lesion which is going into it, knowing about the one is the depth of the lesion, that is a deep margin of the excised specimen, or superficial margin where I am very close to the tumor. So that area I marked it with the normal blue ink, and then I try to save the ink by using a diluted acetic acid so that the ink stays well once the specimen goes in the formalin. The other way around people are using is a dried cucumber or a cork to fix it and use various coloring needles to mark the anterior and the margins of the tumor. Histopathology reporting is negative when the tumor margin is more than 1 mm from the lesion, close when the distance is 0 to 1 mm, positive in presence of tumor at the surgical edge. So close is 0 to 1, and if it is more than 1, it is negative margin. So extra surgical margin taken at that and considered to be definite surgical margins. So negative margin, 6 different margin status. One is negative margin, close superficial margin, close deep margin, positive single superficial margins, positive multiple superficial margin, and positive deep margin. So disease specific or recurrence free survival were reduced in positive multiple superficial, and especially in cases with positive deep margin cases. And disease specific survival was reduced in positive multiple superficial margin, and recurrence free survival was reduced in positive single superficial, positive multiple superficial, and positive deep margin. Close and positive single superficial margin does not affect the disease specific survival. Patient can undergo second laser or can go for a radiotherapy. Deep margin positive should be considered as a single risk factor for transfer laser surgery. Early glottic cancer has an excellent local control rate. LCR for T1 lesion is 86 to 95% various series, and it is almost the same with the radiotherapy also, but there is a difference of 1% or 2% here and there. So close margin, single positive margin, monthly follow-up with high definition NBI-scopy is must. Positive multiple superficial or deep margin intraoperative recording is reviewed, and the patient is go back to the multimodality multidisciplinary discussion on tumor board. What to decide about either the second laser or adjuvant treatment related to radiation or open partial laryngectomy. So using a NBI in the perioperative assessment helps in upstaging of the tumor. We have published our own data of early, almost 5 or 6 years back, about narrowband imaging for premalignant and early malignant lesions using this technique during perioperative assessment of tumor. So single stage transvaginal surgery is lesion with high suspicions of early glottic cancer like keratosis, irregularity, infiltration with high definition laryngoscopy. Lesion has to be confined to two vocal cord with preserved vocal cord function. CT scan must in cases with deep infiltration, like what I mentioned in my previous slide, that body of arytenoid going into the ventricle, arcuate line, anterior paraglottic space, posterior paraglottic space, subglottis, or supraglottic expansion is there. Contraindication of single stage involvement of paraglottic fat, thyroid cartilage, body of arytenoid, the same with which are the contraindication for SST alone. Why anterior commissure is different from the rest of the lesion in larynx? Because anterior commissure is a small area, it is a heterogeneous group, difficult anatomy, difficult exposure. Assessment methods are different. Staging is also different for anterior commissure cancer because of the presentation of these lesions. Advantage of laser surgery in transfemoral in early glottic cancer is, which is a one-session therapy, less morbidity and fewer side effects. It is cost effectiveness and safe radiotherapy for more life-threatening potential second primary and its side effect. So follow for such early glottic cancers. If the early T1A or T1B lesion is there with negative margin, it should be a two monthly follow-up for first year, and then 3 monthly follow-up second year, 4 monthly follow-up for third year, and fourth year 6 monthly follow-up, and then fifth year 1 year onwards. P2 imaging added every 6 months if it is a T2A or T2B growth. Limitation of transfemoral laser surgery, difficult laryngeal exposure and sight. Anterior commissure involvement, craniocaudally, is limitation of transfemoral laser surgery. Invasion of posterior paraglottic space with adenoid fixation, again a difficult situation for transfemoral surgery. Massive infiltration of pre-glottic space, minor thyroid invasion. So on these grounds, the University of Brescia and University of Genova, they have designed a three-dimensional map of isoprognostic zone in glottic cancer by transfemoral laser surgery as a unimodal treatment strategy, and they have divided glottic area into 6 zones. So 6 zones are 6 subcategories. Stage 1 is PT1 not involving anterior commissure, T1B involving the anterior commissure, T2, PT2, that is extending superficial to supraglottic or the subglottic. So remember it, the superficial tumors are different from the deep infiltrating tumors. So sometimes we see dysplasia over the supracommissurial area above the tumor site. So this doesn't mean that the tumor has crossed over. So PT type 4 subcategory is PT2 infiltrating the vocalis muscle. So that has gone to a higher grade of subcategories. Then 5 will be PT3 involving the anterior paraglottic space, and 6 subcategories PT2 or PT3 with vertical extent across anterior commissure with or without involvement of pre-glottic space. So this is analysis by Pariti et al. Pariti and Piazza. Total they have taken more than 400 cases of early glottic cancers. So coming to almost to the end, what Hurtle and given an evidence-based review of treatment option for patients with glottic cancer. It has been published in 2011. So single modality has to be there. Risk-benefit analysis has to be explained to the patient. Morbidity more with multimodality treatment which outweighs the oncological benefit. T2 tumors with normal movement, tumor control equivalent and radiotherapy, external surgery or TLM. To conclude, selection of case exposure, high definition laryngoscopy, optical image enhancement technology and imaging is very important. Unimodal treatment, recurrence-free survival and local control rate and disease-specific survival is very important. All T2 tumors are not same, so official spreading tumor is different from the impaired mobility vocal cord movement. So it doesn't mean that maybe proliferative lesion which is not going deep into that, or it is a superficial spreading tumor. It cannot be labeled like a T2A without knowing the depth of the invasion of that, or is it causing fixation of the vocal cord or not. Unilateral bilateral supraglottic or infraglottic mucosal extension is non-penetrative of cartilage extension in anterior commissure carcinoma, already discussed. TLM requires much experience, advanced surgical skill, proper instrumentation for complete resection of the disease. One should have a good optics, one should have all types of laryngoscope for visualizing anterior commissure, and one should be well versed with the anatomy of larynx. Thank you very much.
Thank you, Dr. Srivastav, sir. Thank you for the wonderful informative lecture. Our next speaker is Dr. Sachin Gandhi, sir. Dr. Gandhi is the director of the Voice Clinic at Dinanath Mangeshkar Hospital, Pune. He is the founding president of the Asia Pacific Laryngology Association and the founding president of the Laryngology and Voice Association. He has numerous publications in reputed Indian and international index journals. He has been a guest faculty at many international conferences and is widely regarded as an authority in laryngology. Over to you, Dr. Gandhi, sir.
Good afternoon, everybody. Thank you, Rakesh, for your excellent presentation. There would be some repeat of a few slides, but I think we'll see more of a clinical images and try to understand the points which both Rakesh and my lecture are going to tell you about managing the glottic cancers, the early glottic cancers with the help of laser. I would just rename my talk as optimizing the functional outcome, that is the vocal outcome in transoral laser surgery for early glottic CA. So we have seen what sorts of diagnostic methods, diagnostic tools and surgical procedures for different glottic malignancies we use. Can we have maximum possible functional outcome, that is of course good voice after undertaking laser chordectomy for these glottic cancers. So both preservation of the glottic structures and reconstruction if required after you do chordectomy. So I mean, going back into the history, people started with punch forceps, like Jackson's in 1995. Then surgical diathermy explained by New and Doughton in 1941. Endoscopic cryotherapy, 1976. And then Strong in 1994, 1975. Ossoff had a good series and I think good many publications. Hoffman, they started using transoral CO2 laser for treating the early glottic cancers. Starting from the vocal cord, they moved on to the supraglottis, more advanced places, and then up to the nearby areas like hypopharynx, cricopharynx, periapitic folds, and rest. So right from punch forceps to Steiner's extended or maybe advanced use of laser in advanced cancers in the surrounding region as well as the supraglottic cancers. What is the indication? What are the indications? So basically, a patient would come with short history of dysphonia, change in voice, exposure to either tobacco consumption, any chemicals, alcohol. There are papers which are published which show direct correlation of acid reflux to development of laryngeal cancers. So alcohol may induce reflux changes which can turn into malignancies. That is also known these days. What is early glottic CA? So basically, laryngeal intraepithelial neoplasia. So grade 3 dysplasia, or known also as carcinoma in situ. T1A, T1B, T2A. So both the vocal cords mobile, either on a single vocal cord or crossing over from anterior commissure to the opposite vocal cord, but still both the cords are mobile. There is a controversy as whether to opt for T2B when the arytenoids are only mobile. We at our institute define early glottic cancers for laser surgery as T1A, T1B, and T2A stages. And of course, the histopathological nature being a squamous cell carcinoma. The investigations, as have been already pointed out, video laryngoscopy, video laryngoscopy, high-speed imaging. We have already seen narrowband imaging or eye scan. I mean, it's the same technology. When it comes with Olympus, it had been termed as narrowband imaging. The Pentax system would note it as intelligent scan or eye scan. Imaging would be necessary when the growth would cross the anterior commissure, or it would go posteriorly into the arytenoid, supraglottis or subglottis extension, and on follow-ups. So maybe PET scan can be done on follow-ups with close margins after 1 or 2 years of or suspicious of recurrence on video laryngoscopy. What are the management options available? Of course, transoral laser microsurgery, radiation. I mean, most of the clinics, they follow radiation because of availability of this technology in different institutes. Those institutes which have a laser setup, they would opt for transoral laser surgery, which already we have seen in the last lecture, and we are going to see further. Partial laryngectomy, maybe these days the indications have gone down tremendously with advanced modalities of radiation and of course improved application of lasers transorally. Type of excision. The margin, the tumor-free margin, you would send for biopsy or you will remove to have best possible oncological results. Either it can be narrow, like up to 1 millimeter. It could be ultra thin margins also. What usually we do in most of the centers and in our center, we take 2 millimeter margin to check for tumor-free status and then term it as complete treatment or completion of the treatment with laser surgery. So type of excision, why it is important? This is important because to have good functional, that is vocal outcome. So as deep or radical you dissect the vocal cord, of course, the recovery of voice function would be less. We are going to see this further in our slides. Narrowband imaging, we are just going through now the images, the clinical images. So what is narrowband imaging? This enhances the contrast of the mucosal surface without use of any dye. So it's a photo diagnostic tool. Of course, early diagnosis of malignancies. It would tell you about the extent of the lesion. You can opt for it during the surgery when you complete your resection of the tumor with good margins. You can still check with your endoscope and narrowband imaging whether the cut margins do have any more disease, and you should go in further to resect it. So basically it can be used intraoperatively to check for the completion of resection. So now you can see this tumor on the right vocal cord. So you can clearly see the interface between the normal mucosa and the pathological tissue. When you have a definite extent, then you can limit your surgery around the lesion and prevent or have the rest of the vocal cord to its normal function. So your excision would not extend further down the lesion. So this tells you about the extents and the margin. Of course, what I was trying to say is optimizing preservation of normal mucosa over the vocal fold. Just to see or compare radiation to transfemoral laser surgery. What are drawbacks or limiting factors for radiation? There may be not more than 250 centers across India, a vast country, mostly in metro cities. Very few of them have recent technologies like IMRT or IGRT. Only few centers have tomography, cyberknife. Rest of them still going for cobalt or linear accelerator. There is a high cost of treatment and of course access to these centers. So there is a long distance for the patient to travel and stay there for 1 month. So it's not a single stage. This is actually multi-stage treatment or multi-session treatment. So the cost also increases. There are factors which would affect the recovery, skin lesions, dysphagia, breathlessness because of the edema into the glottic, into the airway, and of course incomplete radiation, breathlessness and dysphagia during the treatment may land the patient into incomplete treatment. When this patient come for follow-up with maybe not a good voice for them or good phonation for them, then it's very difficult to do any surgical reconstruction for phonatory function. So post-radiation functional reconstruction is not possible because of scarring of the entire voice apparatus. And the main problem with radiation is post-radiation recurrence, which is well known, and these patients can't repeat radiation within 8 to 10 years of first session, and they then land up into complete laryngectomy or total laryngectomy. I think these are the patients to be discussed about. Many of the young patients come with the lesion looking like a papilloma, and on biopsy they turn to be case of carcinoma in situ or squamous cell carcinoma, and you don't know because there is no history of chemical, tobacco or any alcohol use. young patients having papillomatous growth, which comes out to be a malignant lesion, I think it's necessary to send these lesions for HPV typing. Most of them would turn up to be HPV virus positive. These are usually carcinogenic types, type 16 and 18. If they are carcinoma in situ and you are sure about complete excision, you can ask them to go in for immunization. If they are invasive squamous cell carcinomas, you can send them, because they are multicentric, you can straight away send them for radiation. And the HPV positive patients are having a good radio sensitivity and they do very well with the radiation treatment. And actually, I have got almost 8 patients who are following with me for more than last 15 years, and all are doing well. There is no post-radiation recurrence in any one of them. Again, low cost, one session management plan, transoral laser microsurgery. You can opt for radiation at a later stage to treat either a relapse, recurrence, or a secondary primary malignancy in head and neck region. It is useful for young patients. Revision surgery can be opted if there is a recurrence after laser chordectomy. So if a patient, you have done laser chordectomy, comes back after 2 years, 3 years of time, there is a recurrence at the same site or a new lesion on the opposite vocal cord. I've seen all these types, all these cases. Then the patient can opt for a revision surgery, revision laser surgery. I've seen there are minimum 15 patients who are following me up, who have undergone revision surgery with me, and they are following me with me for last more than 10 years. So revision surgery is possible in whatever time the patient comes back. And most important, post-surgery functional reconstruction is possible, which you are going to see in further slides. You already seen, the best possible candidate for laser surgery would be a mid-cord lesion. So both the cord should be mobile and the single cord, mid-cord lesion. Of course, easily exposed larynx, good risk for general anesthesia, and we have already seen, and it should not be a multicentric tumor like in laryngeal papillomas. We already seen in Rakesh's lecture the histopathological examination, but these questions are being asked by either the patient, by other surgeons, and you may have a discussion with your pathologist also. So a thermal energy in the laser surgery swivels the tissue, and this is very important. The first layer shows thermal damage and charring to minimize the thermal damage zone. So maybe what the pathologist should do is discard the peripheral 1 millimeter of the tissue and then start doing the study further, because the first layer is actually the cut margin. Cut margin has to be discarded because of the thermal damage. It will always come as tumor negative. So that margin has to be discarded by the around 1 mm by the pathologist, and then he should start examining the tissue. This is very important. What are the practical points for preservation of voice during laser surgery? We have already seen, if you preserve the non-tumorous part of the vocal cord with a good localization of your surgery, then the patient would have good voice. We are going to see this in few clips. There is always going to be a neocord formation. So whatever tissue you cut, that area is going to be filled up with fibrosis and neocord formation. So it's going to improve post-surgical approximation of the vocal cords. So you should give time up to 8 to 12 weeks for the wound to heal, to neocord to form and have a good vocal improvement. Many of the patients, they develop ventricular phonation to compensate the phonatory deficiency. We have conducted phonatory outcome in patients who have undergone radiation against who have opted for laser surgery, and the phonatory results are equally good in both radiation and patients who have undergone transoral laser surgery. This has been published by me in European Archives 2018 publication. It would be good vibrations from the contralateral vocal cord. This is irradiation with NBI and all these methods, good localization of your things. And again, ultra narrow margins during the resection. So 1 to 2 millimeters surface margins of the perimeter of the lesion. Just to note, if the lesion is in the anterior commissure, you have done type 5A chordectomy, but you have localized your thermal damage with your surgery in the deceased part only and preserved and let the other part function well. See the voice. The patient has developed anterior web, but has a good post-operative phonatory outcome. So there is a web in the anterior commissure. This is a high-speed imaging of the patient. See the mucosal waves in the remaining part of the vocal cord. They are good enough to give good vocal outcome for the patient. So you have to localize your surgery with the help of NBI and other methods you have with your clinic. Again, you can do hydrodissection to preserve the mucosa. You can minimize the thermal damage with ice cold saline application during the surgery, ultra pulse laser, sharp scissors. You should have good exposure with either high frequency jet ventilation or apnea techniques. We have already seen the classification of laser chordectomies. We'll see with this image. This has been drawn by one of my fellow, Dr. Rohan. So type 1 would be when the disease is limited to the superficial epithelium, not going into the lamina propria. So when resection is limited to the epithelium, you would term it as type 1 chordectomy. So the phonatory result would be good. As you go deeper, you include lamina propria also, then it would become type 2 chordectomy. So you have excised the superficial epithelium plus lamina propria, it would become type 2 chordectomy. If you go deeper into the vocalis muscle, then it would become type 3 chordectomy. And if you go into or close to the thyroid cartilage, you include the thyroid perichondrium in your dissection, then it would become type 4 chordectomy. So epithelium, superficial and deep layer of lamina propria, around 2/3 of the vocalis muscle, and the entire vocalis muscle along with the thyroid perichondrium, that would become type 4. So the increased depth of resection would be type of chordectomy, and again the vocal outcome. The extended chordectomy, another fellow, Dr. Darshil, has drawn this figure. So type 5A going into the contralateral vocal cord, into the anterior commissure. So it is involving maybe going along the thyroid cartilage, going posterior to the arytenoid, 5B. 5C is when it goes into the supraglottis and involve the false cord, and down into the subglottis up to 1 millimeter is type 5D. Just to recapitulate again and see in the images, so these are leukoplakic patches or proved to be CA in situ. This is type One chordectomy, this is after the surgery. So it spares the ligament, vocal muscle. The voice is perpetually normal or near normal after surgery. Type 2 is when you include the superficial epithelium along with lamina propria and go up to the ligament. So this is type 2 chordectomy. So this is the lesion and you have gone up to the ligament. So sparing of total amount of vocalis muscle which gives support to the vocal cord. So post-operative voice is perceptually normal or near normal. So type 1 and 2 chordectomies, the phonatory results are best possible in laser chordectomy. This is the lesion on the right vocal cord. This is the stroboscopy after surgery. Approximation is absolutely normal. Voice is also quite normal. The speech is also normal. He is a teacher by profession. So you can reduce by local ice blocks or local cryoprobes to reduce the thermal damage. Type 3, as you go deep into the vocalis muscle, it would become type 3 chordectomy. Type 4 chordectomy is you have gone up to the thyroid cartilage, thyroid pericardium has been removed. We are going to see now principles of laser surgery. As you go along the surgical treatment, we are going to see the clip and try to check the practical measures you apply during excision of the early glottic cancerous lesion. So again, excision of the ventricular band for good exposure. The distal end of laryngoscope should directed towards the side of the lesion. So if the lesion is on the right vocal cord, the tip of the laryngoscope should be directed on the towards the right side. And again, the third hand technique, like your assistants should give external pressure on the thyroid lamina in the neck to give good exposure of the required side. Patient taken under general anesthesia, you first check the extent of the lesion with 0 degrees laryngoscope or a sinus endoscope. This is the lesion, right vocal cord, 0 degrees sinus or laryngoscope, laparoscope you can examine. Take a 70 degrees sinus endoscope to check extent mainly now the anterior commissure and the under surface of the vocal fold. These are two important things. You should also check the lateral extent of the lesion with 0 and 70 degrees. So lateral extent, under surface and anterior commissure. Then you can have multiple techniques available with you. So we are using a 3D camera, also a laparoscopic visualization to check depth of the lesion, depth of the tissues surrounding the lesion. So this is the image, but I mean you would need to wear the goggles to see the depth really, but it helps. It helps to really delineate the lesion and then resect. You can use NBI intraoperatively again to check the extent. Preoperative stroboscopy would be the tool available to maybe diagnose the lesion as being carcinogenic with loss of mucosal waves on the affected side. So the same patient, you can see the mucosal wave in the left cord, but absolutely absent on the right vocal cord, especially the lesionous cord. To have a good exposure, either you can excise the ventricular bands or you can use a false cord retractor to have a good exposure of the surrounding area of the lesion. hydrodissection to preserve the mucosa, and of course to reduce, to have a good hemostasis during the surgery. First and foremost, you have to mark your incision with the laser. All the borders around 2 millimeter apart, the lesion should be marked first, and then you have to start your excision from below upwards, that is posterior to anterior, because if there is some bleeder or bleeding, it's going to drop over down and not obstruct your view. If you start dissecting from upside, then the bleeding would collect there, the blood would collect there, and then you will have to either do suction or cautery or whatever methods, because you can't dissect further. So you should start from posterior to anterior end. Clean the charred tissues to reduce the scatter and again to reduce the thermal damage. And then you complete the excision with the help of laser. After you finish your surgery, again examine with 0 degrees and 70 degrees to check for any remnants of the disease. 0 degrees and 70 degrees to check the anterior commissure and under surface of the vocal cord. See, the under surface of vocal cord is free of tumors, anterior commissure, free of tumor. Again, this is very important. You should have the incision, it should be linear incision. You should not cut the lesion like circular type. You should not give a defect like this, because linear closure, linear vibrations and approximation is important. So your incision should be always a straight line, Again, as you know, vocal cord is a three-dimensional structure. It's not like a paper. So depth of excision also is very important. And you should, this would explain you the depth of the incision. So when you check the margins, it's not only the four margins, that is anterior, posterior, medial and lateral, but also the base of the tumor also has to be examined. And this base of the tumor has to be cleared. And you have to always remember it's a three-dimensional structure. Like for 5A chordectomy, again the lesion in the anterior capuchin moving into the opposite chord. This is after the excision. So this is type 5A chordectomy. Lesion involving the arytenoid. So this is 5B chordectomy. This is after the surgery. 5C chordectomy. So this lesion is going on to the false vocal cords. This is after the surgery. 5D extending into the subglottis, 1 centimeter, not more than 1 centimeter, and another imaging and everything has been done, and any invasion into the cartilage has been ruled out. Then you excise this tissue. And this is post-operative stroboscopic picture. The unsatisfactory vocal outcome after this surgery is basically because of the wide glottis, stiff scar tissue, because there is a thermal damage. You have cut the vocal cord and there could be a stiffness because of the scarring of the tissue. How you do the reconstruction. So if there is a phonatory gap, especially type 3 chordectomy, in which there is going to remain a phonatory gap after the surgery because neocortex is not going to form into the muscle layer. So you can augment this vocal cord with fillers. And what is the best possible filler is fat. So you can augment this with fat. So loss of paraglottic musculature, middleation and augmentation procedures to establish the glottic competence. We are doing this for last almost 15 years, and my paper also has been published in the Indian Journal of Otolaryngology and Head and Neck Surgery. This could be either primary, that is you complete the surgery, you complete the excision, send it for frozen section, and if your pathologist say your resection has been complete, the margins are tumor free, then you can inject the fat at the same sitting, or you can keep the patient under follow-up, and within 2 years, before the tissue scars, within 2 years, you can inject the fat. So this becomes a secondary fat augmentation. This is a case of right-sided glottic CA. This is after excision and fat augmentation. So type 3 chordectomy and fat augmentation. The same patient, we have done stroboscopy after 1 year. So glottic competence is also good. Closure is also good. Approximation is also good. And voice is also good. Type 5A chordectomy, when you excise the anterior commissure, these patients are going to form the anterior web. And just to prevent them to form the anterior web, two things. One is no voice rest after the surgery, let the cords move, and remove the slough in the anterior commissure during the follow-up stroboscopies. So you should call the patient after 1 week and 3 weeks and remove the slough in the anterior commissure to reduce the chances of formation of the anterior web. And even if they form the anterior web, you can just resect it with laser, and if required, you can pass in the keel, or the patient would have a normal voice after the surgery. This also surgery we are undertaking in our clinic. This is a false cord compensation, ventricular phonation after the surgery. This is again a high-speed camera. And the linear incision I was telling about. So glottic competence with linear and vibratory release. So the edge should be linear. So your incision should be linear one. Again, a ventricular phonation and a good voice. If patients are unfit or have bad exposure, then you can opt for KTP laser excision of the tumor in the repeated sittings with laser. So difficult exposure plus hypertension, diabetes, unfit for general anesthesia. This is the lesion, and you can use a KTP laser for excision of the lesion.
Lesion चांगली दिसली पाहिजे आणि त्याला टेकलेलं लेझर.
Then slice the laser and call the patient for follow-up. The last thing to deal with is bulky lesions on the vocal cord. There is no invasion of the cartilage. Vocal cords are mobile. So this is again a T1 lesion, but it is too bulky. What we are following now, we are vaporizing or debulking or excising this with ATP laser. Follow these patients and after 3 to 6 weeks, we are checking the margin with excision with the CO2 laser. So this is a case with a bulky lesion here. TPS laser assisted debulking, and then CO2 laser chordectomy, and this is post chordectomy stasis. Now we have done around 13 cases in last 2 years, and this paper is again, the results are about to get published. Fiber survival, I mean, the success rate is around 95%, and this has been published. Laryngeal preservation rate is 99.3%, and this has been published in JLO in 2015. The first series are 192 cases, and the next paper was published in 2018. It has around 350 cases, again the same findings. So success rate, oncological success is around 90 to 95%. Laryngeal preservation is more than 98%. Thank you very much for your patient hearing. We are just going to go into the short presentation on a new laser, which is known as blue laser. So what is blue laser? Blue laser is a semiconductor laser or a diode laser with a frequency of 455 nanometers, which is close to a KTP laser, which has got around 450, near 450 nanometers, as is this one. The wavelength, so it is close to KTP laser as far as the properties, the surgical properties are concerned. What's the advantage over KTP laser? We have already seen one clip of a KTP laser being used to treat a laryngeal lesion. A KTP laser is a photoangiolytic laser that it breaks the vocal cords and breaks the blood vessels, blocks the blood vessels, and prevents the tumor spreading into the bloodstream. And it is also a vaporizing laser, so it would vaporize the tissue, vaporize the lesion, as well as block the surrounding vascularity. So photoangiolytic property, the same property of photoangiolysis is there with a blue laser, but additionally it has got a cutting property also. KTP laser is mainly a vaporizing laser, so it's not going to cut, but it's going to vaporize the tissue. You are not going to get a good margin. I mean, we have seen a bulky lesion, I have vaporized it with KTP laser. I removed it with KTP laser, so I will not be able to cut with a good margin. The blue laser also has a cutting property, so it has got both photoangiolysis as a KTP laser with cutting property. Okay. It again a fiber transmissible laser, but the fiber which carries the laser beam is a narrow one as compared to a KTP laser. KTP laser would come in fibers or around 600 to 800 nanometers. This would come as around 300 to 400 nanometers. Being a semiconductor laser, this is quite portable and do not require any wear and tear or maintenance. You can reduce the pulse ratio, that is a repeat mode, or pulse duration, that is a pause between the two shots of the laser, up to 1 millisecond. Again, advantage over a KTP laser. It has got very good cutting properties and tissue effects. These are comparable. I mean, the cutting properties makes it different from KTP laser, and now people are started comparing with it with a beam laser, that is a CO2 laser. So it is, cutting properties are like a CO2 laser. Main thing actually, it has got a low cost as compared to KTP and of course CO2 laser. But mainly being a fiber transmissible, if you compare it with KTP, the cost is almost half of the cost the KTP laser available in India. The limiting factor again, we are going to see few clips, but then there is a calling as a blinding effect. So it's not to be a continuous fire or continuous emission of the laser beam. There are always is going to be, because if you fire it quite fast, then there is going to be blinding effect of laser which we are going to see. Apart from that, it's a good laser, portable laser, and cost is also less as compared to KTP and CO2. This is a absolutely small size portable laser machine. Again, comparing it with the KTP, the same thing. Fiber size is thicker and thin in blue laser. Portability is quite good. Because it is thin, you can use it in office-based procedure through your flexible laryngoscope, being thinner than the KTP laser. So clip, there is an intercommissure mass here. See, I'm firing it with KTP, the blue dye laser. This blinding effect actually is not really good. You can't see it throughout. The visualization during your shots is not that good. This is laryngeal papilloma in the posterior commissure, and we are passing it through the flexible laryngoscope and doing it as a OPD procedure. You see, when you are firing, there is a landing effect. This is a space of a stapes surgery. The stapes tendon exposure being not good. I was not able to pass scissors, fiber laser. So when you fire, that is some blinding effect which yeah, see. Thank you for your patient hearing. Now I'll request uh, our colleague in voice clinic, Mrs. Khushali Desai, for her talk on voice analysis and voice therapy in voice clinic. She has completed her master's in speech language pathology from Mumbai Aliawar Jung National Institute. She is working with us as a consultant since year 2001. She has special interest in assessment and management of voice disorders and care of professional voice. Core team member of special clinic for professional voice users. He was awarded a clinical attachment to North Riding Infirmary and James Cook Hospital in UK in 2001. May I request Urshali to start her talk on voice analysis and voice therapy in voice clinic.
A very good afternoon to everyone, and welcome to this session on Laryngology Back to Basics. I'm here today to give a brief overview about the voice assessment and therapy as undertaken by a speech-language pathologist in a voice clinic setup. The management strategy can be outlined as follows for any particular voice disorder. We begin with the medical evaluation, which includes a detailed case history and visualization of the larynx. This is followed by a diagnostic voice evaluation, which includes typically the perceptual, acoustic, aerodynamic, and self-rating scales, which are administered on the patient. This leads us to formulation and thereby helps us to decide the direct voice intervention strategy that's going to be applied. It could be either medical line of treatment, surgical, or a behavioral mode such as therapy approaches. All of this above is, of course, included along with counseling of the patient at various stages. Let's see a brief overview of methods of the voice assessment. These methods are as follows. As mentioned earlier, a detailed case history and interview of the patient, which gives us an insight into the history, such as any medical or surgical related issues, the onset of the voice problem, the duration, any particular professional commitments related to this onset, etc. This is followed by a detailed auditory perceptual evaluation, acoustic analysis, aerodynamic measures, the laryngeal imaging procedures such as stroboscopy and high-speed imaging, and quality of life measure. A lot of times, all of the above measures are included by certain tests of vocal loading, which are specially included when there are professional voice users involved, because a particular person's performance on vocal loading could be affected by even a slight dysphonia. These methods of evaluation are usually decided depending on the setup in which we are working. That is, a medical setup would entail a more etiological diagnosis, whereas a voice clinic or a laboratory kind of setup would give us more or would focus more on the functional voice measures. Now, coming to the first assessment, that is your perceptual measures. The physiological basis of perceptual measures are as follows. Here, the three main domains which are assessed are the pitch, loudness, and the quality of voice. The pitch depends largely on the effective vibrating mass of the vocal cords. So in case of any mass lesion, we always note that perceptually we can hear a slight thickening of the voice, as we explained, which is nothing but lowering of the frequency. Or a particular muscle tension dysphonia may give rise to a perception of a higher frequency of the voice, or a higher pitched voice. Some of the measures which we evaluate here are the habitual pitch, the pitch range of the patient, and presence or absence of pitch breaks. The loudness largely depends on the true vocal fold contact, and hence any change in the glottal configuration due to absence, presence of a lesion, or any weakness of a particular vocal cord can affect the habitual loudness as well as the loudness range. The quality of voice, as judged perceptually, is usually affected by the vibratory symmetry and regularity of vibration of both the vocal cords. A very simple perceptual analysis procedure, as given by Hirano in 1981, is the GRBAS or GRBAS, where G stands for the overall voice quality, R is the feeling or the perception of irregular glottal pulses, which are usually seen in cases of glottal fry, diplophonia, etc. B is the auditive impression of air leakage, that is breathiness due to insufficient glottic closure. A is the asthenia or weakness in voice, and lastly S stands for the strain in voice. All of these measures are rated from 0, normal, to 3, severe deviance. As we can see here, we can hear this particular audio sample. This can be rated as given below. So listening to a particular voice sample again and again, this being in a non-invasive measure, we can evaluate the patient's voice at each review or each session. Coming next to the aerodynamic measures. The aerodynamic measures are basically related to the airflow and air pressure, which is used by the vocal cords during voice production. So it basically evaluates the functional status of the respiratory system. A very, very simple measure of aerodynamic measure is nothing but your maximum phonation time, where the normative is considered to be higher than 15 seconds. And it reflects the fatigue effects as well as coordination of all the systems involved in voice production. Secondly, the Serzer ratio, where the normative is considered between 0.9 to 1.1, reflects a degree of vocal fold closure and the respiratory control, thereby affecting it. There are some other equipments such as the phonatory aerodynamic system or your pulmonary function test or a basic spirometer, which can also give you measures such as the vital capacity, that is the volume of air expelled after a deep inhalation, or the phonation quotient, which is the ratio of the vital capacity to the maximum phonation duration, which is again an indicator of air consumed for voice production. All of these aerodynamic measures are very, very important while evaluating any person with a voice disorder. Coming next to the laryngeal imaging, that is your visual, again, which is a highly subjective and visual perceptive tool. And it includes your stroboscopy, first and foremost, the stroboscopy, which is the gold standard of voice evaluation. The stroboscopy, as we can see here, it evaluates a number of measures, as all mentioned, the glottic closure, which is depends upon how it is, whether it is a regular closure, it's an open or a closed closure, or it's an hourglass closure sometimes when there are lesions involved. Secondly, you have the mucosal wave amplitude, the symmetry and periodicity of the mucosal wave, the vibratory pattern, any kind of hyperfunction that could be present in order to compensate for a particular deficit. Then you have the arytenoid movements, which could be either normal or irregularity or hyperfunction of one side. And then you have the ventricular movements. This particular scopy as seen here, this is just to give you an example of how we evaluate the vocal cords during stroboscopy. Some of the stroboscopy systems also provide an electroglottograph alongside the, and we are able to get a measure of the frequency and amplitude of the particular individual phoneme. So the patient's voice is evaluated at comfortable pitch and loudness, as well as in other modes such as the high pitched mode, the low pitch, or a pitch glide. The next laryngeal imaging, which is very, very useful for research purposes, particularly, is the high-speed imaging, and it has a particular advantage over stroboscopy in the sense that it provides detailed motion of the vocal cords, and it extracts these two particular patterns to us, that is the montage, which gives you a detailed analysis of each vibratory cycle, the open, the opening, the closed and closing phases. And the second one is a kymograph, which is nothing but a line scan. That is a particular, it gives you the features of left-right vocal cord, vibratory symmetry, and periodicity. A very, very popular analysis among the speech-language pathologists is the acoustic analysis, which gives us the functional status of the voice production system. And it is extracted using a lot of instrumentation. So there are a number of different softwares which are available for carrying out this acoustic analysis. It is a visual representation which helps to aid in our perceptual judgment of the stroboscopy. It is, of course, objective, reliable, and time-saving, and very, very important, it is non-invasive. It's not really particularly representative of any voice disorder as such, but it helps in the overall evaluation by supporting the findings which are obtained from the other measures. It's particularly useful in pediatric cases because we can repeat this particular analysis at every therapy session or every time the patient comes up for a review or a follow-up. And the acoustic paradigm that is obtained through this analysis can help us often in making decisions regarding the treatment options, as in whether to continue with the voice therapy or go in for a particular surgical approach, etc. So it gives us a particular baseline, and then we can compare at each session with the baseline to see how if there is any improvement in these measures has taken place. So what are the different measures that can be used for acoustic analysis? It is the frequency related parameters, the intensity related parameters, and the quality related parameters. This is again in accordance, again similar to the perceptual evaluation. So this is an example of a radial graph which is extracted through the multidimensional voice program. And here we can see in the figure there is a range of parameters here which we obtain from a single voice signal, and it can give you short and long-term frequency as well as amplitude perturbations. It can give you information related to noise parameters, related to tremor parameters, as well as voice break and subharmonic factors. And with each evaluation, you can actually see if there is any difference in these particular measures. So this is a particular pre-post comparison that we can see here of a patient. The first graph on the left side gives you the pre-therapy evaluation, wherein most of the perturbation measures and the noise measures are elevated. And the second graph shows almost near normal or a normal radial graph where all the measures have seemed to improve. So this gives a very good visual representation to the clinician performing the analysis as well as to the patient. Lastly, we have the self-analysis, which is actually the client's perception of this particular voice disorder that he has and how it is affecting in his daily life. So the voice handicap index and the recent one, the voice handicap 10, is a very, very useful method wherein the patient fills out certain questionnaires, which are 5-point rating scales, and there are 30 items in this related to the physical, emotional, and functional domains. And we can rate the handicap from mild to severe. This is again similar to the acoustic analysis. It's a very important index which can give us good information for comparison between the baseline and the post-operative or post-therapeutic measures. Now, as I have mentioned, all the commonly used tests of voice assessment, let us see how we can use all of these tests for collating our results. So example, there is a patient who's a 17-year-old male with a history of hoarseness of voice since childhood. His maximum phonation time is about 10 seconds. There is no particular medical surgical history related to his voice problem. And the perceptual measures as rated on GRBS are G2, R2, B2, A1, and S2. His voice sounds something like this. The acoustic analysis or the radial graph obtained with the acoustic analysis looks something like this, where we can see that there is significant elevation in the jitter, shimmer, the noise measures, particularly the voice turbulence index, as well as there is some amount of voice breaks and degree of subharmonics present in this particular sample. The endoscopy looks something like this, where you can see that there is inadequate closure caused by these sulcus which is present on both the vocal cords. So we can collate the result as the functional diagnosis could be hypofunctioning voice system due to the presence of bilateral sulcus vocalis with a significant phonatory gap. So this is the way we can actually correlate all the results obtained through the voice assessments. If we have a uniform method of reporting wherein we give a functional diagnosis which is more related, which can be given by a speech language pathologist and related to the etiological diagnosis given by a medical specialist or the laryngologist, then it will help us to correlate and overview the results over time, and we can easily compare it also across different clinical setups. Now coming to the second half, that is the voice therapy. The speech language pathologist is of course involved in this intervention method also. The voice therapy is provided with the goal of maximizing the vocal effectiveness, restoration of the laryngeal health up to the extent possible. So the laryngeal health could be compromised due to a functional issue such as misuse or overuse of voice, giving rise to different functional misuse patterns. It could be affected also due to some organic lesions such as a nodule, polyp, or a cyst or vocal cord paralysis, to name a few. And the third voice therapy goal is elimination or reduction of the functional impairments which have caused or which are related to the voice. So voice therapy could be indicated in any of these scenarios. It could be the sole treatment approach, which is very, very commonly used in patients who have soft vocal nodules, who have a very short standing paresis or vocal cord palsy. It also could be due to muscle tension in case of muscle tension dysphonia. Voice therapy could be provided as a pre-operative intervention strategy for patients with the aim to reduce the edema and the edema surrounding the lesion, to reduce the misuse patterns or the hyperfunction or compensation which are taking place. We can also provide advice in the pre-operative voice therapy period, where we give an advice regarding vocal hygiene, hydration, and anti-reflux measures. It could be, of course, provided in the post-operative period for some clients who have lesions such as a vocal cord cyst or a hard vocal nodule or a polyp, wherein we try to help the patient regain his voice quality and reach normal voice quality as far as possible. And in some cases, it is used as an adjunct to surgery very often. In cases such as the patient has undergone laryngeal framework surgery or undergone fat augmentation surgery for a hyperfunctioning system such as vocal cord paralysis, unilateral vocal cord paralysis, where therapy is very, very important as a supportive measure to the surgical improvement that has taken place. The following are the voice therapy orientations which are very often used. The hygienic voice therapy focuses mainly on altering the vocal hygiene, which is kind of compromised, and wherein we see that there is a lot of phonotrauma behavior that's happening. So it also includes advice regarding following vocal hygiene programs, following the right amount of hydration, etc., and correcting it. Then we have the symptomatic voice therapy approach, which actually only works on certain symptoms, such as decreasing the fundamental frequency or lowering the frequency in individuals, or in some cases, decreasing a particular breathiness aspect. So it works on a particular symptom, and there are a list of therapy approaches which are used in this orientation. Then you have a psychogenic voice therapy, which includes a lot of counseling and giving importance to the patient's mental as well as the vocal health, and counseling regarding awareness, etc. about this problem. A very important domain which we use very, very often is the physiologic voice therapy, which focuses on the altering or kind of changing the physiologic correlates, which are which are basically causing the voice production. So if we give a lot of importance in viewing the laryngeal imaging procedures, correlating it with all our assessments, and then trying to alter the physiology through voice therapy approaches. And lastly is the eclectic voice therapy approach, which is basically a combination of all the above mentioned approaches. It focuses basically on the individual and tries to alter the voice, different voice characteristics, taking into consideration all of the above approaches, which is particularly and customizing it to that particular individual. So when a clinician is basically is assessing a particular individual and kind of comes to formulating a diagnosis, then he's often confounded as to which approach to use. But I think the very, very important thing here to notice that we need to choose a treatment approach which is well supported by evidence. Then it takes into consideration the need of the patients as to what is the need or the demands of the patient, where and in which situation and for how long the voice use is to be there. And of course, on the ability on the part of the client or the patient to understand the instructions given in therapy, as well as the ability of the clinician to help the individual understand and learn the various therapy exercises. So when with patient coming with a voice disorder, we often see that there are many commonalities, like the patient complaints could be very similar. The patient complaints of vocal fatigue or difficulty in phonating towards the end of the day, or roughness in the voice, etc. There will be a lot of common auditory perceptual findings that you can see. There would be a few stroke findings would be common, as well as the functional impact of this voice disorder could be common. So all of these can vary, but the responses which we see in the underlying physiology, that is either your compensatory hyperfunction due to a glottal incompetency or hypofunction of the respiratory and phonatory system. So most often as speech pathologists and therapists, we focus on these common responses which are affecting the physiology and try to come up with a treatment plan which is best suited for this particular individual to improve his voice quality. So here is an example of how we frame the clinical question whenever we are deciding about the therapy. So if it is a patient of pubophonia, as is in the first scenario, then we usually try to provide therapy using some of the symptomatic therapy techniques, which are undertaken to lower the fundamental frequency or the perception of a pitch in the particular individual. And this is done with a proposed outcome to come to age-appropriate fundamental frequency or age-appropriate pitch. In a second scenario, which could be vocal nodules, we try to intervene with the help of a vocal hygiene program, which is more like a hygienic approach, and combined with the physiologic approach, such as the vocal function exercises. And this is basically undertaken to reduce the roughness and voicelessness which is present in the voice quality of this individual. If it is a patient with a bilateral sulcus vocalis but has undergone certain surgery, such as a fat augmentation surgery, then here I would propose more of an eclectic approach, because we are aiming at near normal voice quality. We have undertaken pre-operative voice therapy. We have the patient has also undergone the surgery, and here we can make sure that with the support of therapy as well as surgery, we can aim for a near normal voice quality. So here an eclectic approach can be very, very useful in framing the particular management strategy. So these are some of the examples which I have provided here. So to conclude, in order to obtain a good outcome for vocal effectiveness, we should always focus on multi-parametric voice assessment, because as we all know, voice is multidimensional. It is a combination of various systems which come together for producing the voice. So assessing the voice at different levels, that is the aerodynamic, perceptual, resonatory, the laryngeal imaging, all of this should be undertaken as far as possible in the single test battery approach. Always we should remember that outcomes data serve as the foundation of clinical practice in voice pathology, and evidence-based practice identifies the most efficacious therapy techniques. So we should always focus on using treatment techniques which are very, very well backed by evidence, which have been studied well. And lastly, treatment effectiveness needs to be highly individualized to that particular individual. Thank you very much for a patient here.
Thank you, Vishali, for a wonderful lecture. I think we'll take on some questions that have been asked by the delegates or the viewers. The first question: how to perform HPE relative study in larynx? I think I will take it in this context of malignancies, laryngeal malignancies or early glottic CA. Just to define, I can find three studies which we are about to undertake. One, as I have already told, about to see the progress or conversion of premalignant lesions into the malignancy with tumor markers. So when we excise the premalignant lesions, then do the tumor markers and then accordingly follow the patients. That is one study which we can take in larynx. Another thing is basically when we see a patient having a suspicious cancerous lesion in the larynx, we always tell the patient it's not definite diagnosis on OPD, but looks suspicious to be malignant. So what are we are going to do? We are going to take you under anesthesia. With microlaryngoscopy, we are going to remove a small piece of it and send it for histopathological examination. So what we say is a frozen section. If it turns out to be malignancy, then we are going to go ahead with chordectomy. So we can always compare results of frozen section with the final HP. That's maybe the another study which actually one pathology resident in our institute has already done. And last would be the margins. Actually, the pathologist would report your excision with tumor-free margins. So how many, I mean, you just follow them, how many of them are false positive or false negative results that you can study. So I think these three areas as related to treating early glottic cancers, I can see you can do a study as far as laryngology is concerned with respect to histopathological examination. Next question from my boss, Dr. Mr. Oswal. Define early glottic carcinoma at OPD level, revision of the same after assessment and excision, and again revised post-op diagnosis with HP. So, I mean, as the patient comes with hoarseness of voice and some lesion on the vocal cords, in the OPD settings, we are going to examine his vocal cords with the help of either a video laryngoscopy or video laryngostroboscopy with additional narrowband imaging or eye scan, whichever method is available to you. That is going to raise the suspicion about that lesion to be malignant. But OPD examination or endoscopic examination, even with NBI, would raise the suspicion. It would not be a definitive diagnosis. Definitive diagnosis to be that lesion a malignant one would only come after histopathological examination. So I think on the OPD, if both the vocal cords are mobile, plus the imaging would show no invasion of any cartilage, either the thyroid cartilage in the anterior commissure or the arytenoid or the cricoid cartilage in the subglottis, then that could be an early glottic carcinoma. But again, a suspicious. It can altogether change after you send the specimen for histopathological examination. So I think the histopathological examination first would confirm it to be malignant, and then it would say it has invaded maybe the lamina propria, it has spared the muscle fibers or spared the perichondrium. But the histopathological examination would make a definitive diagnosis about the invasion of the lesion or whether really it is early malignant. But yes, on OPD with endoscopy and with these photodiagnostic tools, you can take it as a case of likely early glottic carcinoma, explain to the patients the various options available, and then treat it accordingly. Definitive, of course, it would come on histopathological examination. Yes, so post-operatively, it's going to be specific what kind of malignancy it is. Either it is a squamous cell carcinoma, it is aggressive type of squamous cell carcinoma or some other variant, and whether it has got a tumor-free margin or not. So as I tell my fellows, even if you see a lesion on the edge of the vocal cord, likely to be malignant on your OPD study, will not be able to tell the patient whether you are going to do type 1 chordectomy, type 2 chordectomy, type 3 chordectomy, or type 4 chordectomy. Number one, when you take the patient for surgery, during the surgery, you would know the likely invasion of the disease. So maybe a type 1, as you see clinically, may go on to type 3, because during the surgery, you can see the tumor invading quite deeper. So then you go on resecting for the negative margin. So that is during surgery. And after the surgery, when you send the specimen for histopathological examination, then whether your excision is complete or not, that the histopathologist would tell us. And if it is complete and you have got a tumor-free margin, then it really becomes early glottic carcinoma or not. There have been many studies which have been done, and they have compared NBI findings with histopathological examination. And some studies say they are close to, 80% similar results. So around 80% would be the right diagnosis. So I think the false negative results are quite less, but as yet, not a single photo diagnostic tool has been proved or has been accepted as a diagnosis of cancer or malignancy at OPD level. I think this may be answer to this question. And as far as anterior commissure, whether we can consider it is as early glottic CA, I think again, if vocal cords are mobile and imaging doesn't show any invasion of the thyroid cartilage, then anterior commissure lesion would be an artiglottic carcinoma. It is considered as a separate entity because of anatomical differences, because there is no perichondrium around, and because of difficulty in exposure during the surgery. So if the imaging finds there is an invasion of the thyroid cartilage, then you have to go in for type 6 chordectomy or maybe radiation and maybe partial laryngectomy itself. I think thank you very much all of you for attending. Yes, Darshan.
Yeah, I would like to make an announcement. As I said earlier, this session is going to be the last session of the first module, which is on voice. From next month onwards, we will be starting our next module, which is airway. It will be having 2 sessions, and after that, we'll be having the last module, the third module on swallowing, which will again have 2 sessions. The certificate for the first voice module will be available over the next week. All the participants will receive an email with a link from which the participants can download their certificates after appearing for a small assessment. So
thank you.
and
And please remember, because of difficulty in few of the speakers, we have shifted our session to 4th Saturday of next month. That would be 24th of September 2022. So 4th Saturday of September, that is 24th of September 2022, 4 o'clock. Please join us for the next module, that is airway module. Thank you. Thank you very much. The speakers, participants, and my assistants and colleagues. Thank you.
thank you, sir. Thank you, everyone.